All right, folks. So for our last class, we're going to talk about clinical psychology, also known as abnormal psychology. If you go on to take psych courses and you're interested in this particular subject, that tends to be listed as abnormal psychology. But basically what we're talking about here are mental disorders. And so we're going to go through basically what it means when we say mental disorder, what's a definition of that, and how we came to that. We're also going to talk just briefly, because we only have one class to do this, we're going to talk just briefly about some of the most common, or in my previous classes, some of the most asked about mental disorders. And then stick around for the end of this video, because we're going to talk about the final exam and just give you a little bit of information about what's going to be on that. So first, let's go ahead and jump into what we're talking about, mental disorders. So I feel like the first thing that we have to do is define what a mental disorder is. And this may sound relatively easy just on first glance, but actually defining what a mental disorder is, it turns out to be pretty complicated. Usually, if we were having class in person, I'd go around the room and I'd ask folks to tell me what they think a mental disorder is. How would they begin to define that? And often what I'll get are different pieces of what the actual definition is. So I'll hear some things like, this person is out of the norm, or this person is suffering in some way, or this person can't control their emotions. So these types of things often come up. But what's really interesting about mental disorders, clinical psychology as a practice, of course, is that it's really difficult to nail down what a mental disorder is. Again, it turns out, and we've been doing this for a while, that is to say, diagnosing mental disorders. We're on the DSM-5, which is the manual that we tend to use to diagnose mental disorders. And every time one of those manuals gets updated, again, we're on the 5, they change the definition. Now, they don't overhaul it usually. They sometimes add a couple things or take a couple things away. But what that should tell you is just that is a very fluid, living, moving definition. And broadly, this is some people's problem with psychology, but we are doing the best we can. And again, this is just something that's difficult to nail down. So what are we talking about? What is this definition? So this is from the DSM-5. It's on page 20 if you happen to have one. And it says, mental disorder is characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior. So that's the first part I want to get into, is a mental disorder is a syndrome characterized by a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior. So cognition, of course, is what we're talking about when we're talking about someone's thinking. But remember, as I've stressed before, cognition doesn't just mean the words in your head, it means also your thought processes. So the way that you come to conclusions, the way that you understand logic, the way that you interpret what's going on in front of you, right? All of those are cognitive processes. And so when we say disturbance in cognition, we mean some disturbance in that process. It could be some disturbance like voices in your head, for instance, but we're not just talking about those things. We're also talking about that broad array of what we call cognition. So the other piece is a disturbance in emotion regulation. This is called emotion regulation and not just emotion, because we're not saying that somebody has a disturbance in emotion and that makes them have a mental disorder. But what does define a mental disorder, or does get closer to it, is a disturbance in the regulation. So it's one thing if, your dog dies, God forbid, and you're upset about it, but you go to class or you go to work or you still have interactions with your friends and loved ones, and you're just processing that grief. Or even if you take a couple days or you take a couple weeks or whatever it takes, and you get through the grief, right? But it's another thing if that happens to you and you're crying so much you can't go to work, and you're so upset that you can't go outside because you might see another animal and that reminds you of your dog, right? If the emotions are so much that you can't regulate them and get what you need to get done, then we're talking about a problem. Not just having the emotions, but having some difficulty regulating them. So that's why that says that here, emotional regulation is one thing that we might look for. And then lastly, disturbances in behavior. So this might just mean literally movement, or it might mean actually doing strange things. So sleepwalking is kind of a psychiatric disorder. That is to say, it's psychological, but also medical. But that's a good example, right? That's not a disturbance in the way the person's moving, but it is a disturbance in their behavior, in the sense of they're doing something that's out of the ordinary. So this first part of the definition, a mental disorder is characterized by clinically significant disturbance in cognition, emotion regulation, or behavior, is basically letting you know what the psychologist or what a mental health practitioner is able to treat. That is to say, what are the symptoms that are going to show up that are going to be something that a psychologist, a clinical counseling psychiatrist, a social worker, what are the things that they can treat? Well, if they have a disturbance in their cognition, their emotion regulation, or their behavior, that might be something that is grounds for them to see someone who's a mental health specialist. That is to say, versus they're just going through a normal thing, or maybe they should go see a medical doctor instead. So those three things are the three things we can treat. This definition goes on. It is really long, which is part of the point. So it's one of these disturbances that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. So now we've got this other list of three things that reflect a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. So what does that mean? And now why are we getting into biological and developmental if we're supposedly just talking about psychological disorders? Well, what this part of the definition is trying to tell us is that these are the places that some of these mental disorders may come from. That is to say, they may come from a psychological place. Your dog died and you're having a hard time coping with that. But they could also come from a biological place. You were born with autism spectrum disorder, right? And though we classify that as a mental disorder, that's something that is really just in the biology. That's just the way the brain of folks with autism spectrum disorder are made up. Or something that's developmental. And so a developmental disorder is something that you kind of grow into. Schizophrenia, we'll talk about this in a little bit, really fits this, though you might still call that just a psychological disorder. Autism also, I've already used that one, but also autism also fits this. Sometimes ADHD might fit this in terms of it being a childhood disorder, though a lot of folks don't, like myself, honestly, don't grow out of ADHD, but if it is something that they're just dealing with as a child, we might call that a developmental disorder as well. So all of those things are just places that a psychological disorder, a mental disorder might come from. They may just be psychologically based. Something happens and you're interpreting it in a certain way, and that's causing you distress or to be depressed or something. Or again, maybe it's just something biological, or it's something that's a phase, or something that you grew into or will grow out of. So we can treat things in the domain of cognition, emotion, regulation, in behavior that are coming from the psychology, the biology, or some developmental process. The definition goes on: mental disorders are usually associated with significant distress in occupational, social, or other important areas. What this is saying is that in addition to these things just being clinical disturbances, right? That these are just out of the ordinary. You think differently. You hear voices. You have trouble regulating your emotions, or you're a sleepwalker or something like that, right? In addition to these things just being some type of disturbance, they also should cause distress. It's not enough that they're just out of the ordinary. It's not enough that, everybody doesn't think the way you do. Everybody doesn't have the same cognition that you do. But is it causing you problems, or are you just different, right? Here's what we're trying to get at here. That is to say, we're trying to be careful not to diagnose people who are just out of the ordinary. And so it's one thing, again, if you just think differently, right? Some people are synesthetes. That is to say, they see colors and hear smells and this type of thing. But does it cause distress? Is it so bad that they can't get a job? Is it so bad that they can't go to work? Is it so bad that they can't get up in the morning and again do what they need to do? So if the disturbance, or if that difference is so bad that it's distressing, and that distress just means it's harmful or it's hurtful in some way. If that distress is in you, that's one way to notice the distress, right? I don't like how depressed I feel. I don't like how anxious I feel. The voices I keep hearing are scary to me. That would be the distress in the individual. But one thing that we also pay attention to in psychology is you may be doing distress to other people, or you may be doing distress to your life that you yourself aren't even noticing. So, for instance, if you're a narcissist, you're going to be pretty proud of who you are and what you're about, but you may be having a hard time getting a job because people are saying, who's this guy applying for the entry-level position that thinks he should run the place? Or you might have a hard time in a relationship, right? So there might be these other distresses that aren't felt internally, that aren't felt psychologically, but we would still note that, right? So that important piece, and for me this is the most important piece of, is it causing some distress? In psychology, we're really taking this tact that it's only a problem if it's a problem, because again, because this definition is so amorphous, we have to be really careful not to just capture people who are different, and that's okay. So it goes on to say, we're halfway done. An expectable or culturally approved response to a common stressor, such as the loss of a loved one, is not a mental disorder. So this is trying to also give us room. This definition is trying to do a lot. This part of the definition is trying to say, listen, there are times when just as humans, we're going to have a hard time regulating our emotions. We're going to have, behavioral abnormalities. We're going to think in strange ways. But sometimes those things are just related to what's going on in our life, or maybe it's just a cultural thing. So take, for instance, again, they give the great example of death of a loved one. And so someone grieving, we wouldn't want to diagnose them with depression, because that makes, grieving the loss of someone that you've lost, that makes that a disorder. And so we have to be able to just recognize also normal human processes and differentiate them from grief or other things that are just normal. So for instance, in some cultures, it's normal that, if a baby's going to be born, or maybe an elder in your family dies, that maybe they visit you in a dream, or maybe they send you messages when you're praying or meditating or something like that. And if that is the culture that you come from, well, that's kind of a culturally acceptable or a culturally expected way to behave. And so again, we would isolate that from a mental disorder. That person isn't hearing voices in the sense of some type of psychosis. They're hearing voices because that's how their culture, deals with the loss of someone really important to them. So, making sure that we're understanding that just because someone's in distress, or just because something's out of the ordinary, that doesn't, again, necessarily make something a mental disorder. Here's something else that isn't a mental disorder. Socially deviant behavior, such as things that are political, religious, or sexual, and conflicts that are primarily between the individual and society, are not mental disorders. So this is trying to say, if a person is choosing to be different, if a person has a strange political bent, if a person has a strange religious or sexual practice, and it's not causing distress, it's not due to some biological abnormality, etc., etc., it's just that they're different, well, and they've chosen to be, that is to say, it might cause some distress to the people in their lives. Even today, if you come out as transgender, that might be a problem for the people in your family. You might be experiencing some distress in terms of, how do I deal with this, or how do I tell people in my life, that type of thing. Well, we wouldn't classify that as a mental disorder, because that's a sexual thing that, first of all, we know as an orientation. That's more of a gender piece, so that's a gender piece that we know is just internal to who a person is. And so then dealing with that isn't necessarily what we would consider a mental disorder. I say necessarily because sometimes, this is an aside, we would consider the distress, if the distress is so much, again, they can't go to work, they feel like they can't talk to anybody in their family, right? We call that gender dysphoric disorder. And what that has more to do with, I think that's the term, they changed it recently, but basically what it's saying is, it's not that you're transgender that's the disorder, it's the distress it's causing you in your life, because you're having to deal with it in such a way. So we try to be really careful not to put people in this box. If you're, I don't know, a fascist or a communist, and everybody in your family thinks that's weird and they want to throw you out, so that's causing you distress, you've lost your inheritance if you had one, right? This type of thing, again, causes distress. It's abnormal, it's out of the ordinary, you're thinking differently than everybody else. We could capture that as a mental disorder, but we can also know that you've made that choice in your life, right? That this is just a political difference that you're having, same as a sexual difference or a religious difference, right? Hearing voices of somebody who's passed. The last little piece of this definition says that those things can be disorders if they're caused by something above. So if you are joining a religious cult because you've been hallucinating voices that tell you that the only way to save yourself is to, I don't know, join this cult over here or whatever it is, then again we loop back around and say, well, that is caused by disordered thinking. It's causing you harm. You're not choosing that thing so much as it's happening to you. Then we would classify that again as a mental disorder. So I'm just going to read it all again nonstop because I broke it up so much. A mental disorder is a syndrome classified by a clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress in social, occupational, or other important areas. An expectable or culturally approved response to a common stressor or loss, such as the death of a loved one, is not a mental disorder. Socially deviant behavior, such as political, religious, or sexual, and conflicts that are primarily between the individual and society are not mental disorders, unless the deviance or conflict results from the dysfunction in the individual as described above. Again, DSM page 20. So now I just like to talk about some of the most common mental disorders. Usually what I do in class is I'll get a list from you folks, you students, and figure out what are the most common mental disorders that you're interested in. And so I'll just take a list and have you write down 2 or 3 that you want to hear me talk about, and then I would choose the most common ones. Obviously we can't do that, and so what I'm going to do instead is just choose the ones that tend to come up most recently, most usually, and the ones that are kind of just most common that we would see in a clinical practice. So I don't know if I told you this because we started class in a strange way, but I spent 2 years before coming to UCM, and then about 7 years before that, while I was in graduate school, working in clinical practice as my training towards my PhD. So I usually save this one for last, this topic for last, because it's something I have a lot of interest in, and rather end with something I'm knowledgeable about rather than a whimper, so to speak. So some of the things that I've done include working at college counseling centers. I've worked at veteran affairs offices. I've worked at a children's advocacy center, where we would see children who were coming in from abuse or coming out of some type of neglected home or something like that. And then I've also worked in community counseling centers, which are usually just low-cost counseling centers for folks in the community. I think there are a couple of those in Warrensburg. Some of our graduate students sometimes get some work there, but usually they would offer appointments for anywhere from $5 to $20 a session, which is much less than I charge now. But it was just a way for folks in the community to get therapy if they needed it. And of course, it was helpful to us because we were training at the time. And so, they were getting cheap therapy and we were getting the training that we needed. So the most common thing that I would see is anxiety. I almost say depression, but I think I often saw more anxiety in the places that I was working than I saw depression. And so when we talk about anxiety disorders, this actually isn't a section in the DSM anymore. They've split them up into, there's just so many types of quote anxiety disorders that they split them up into different sections to kind of try to really nail down more of what they are. So there is something called a general anxiety disorder, and this is a disorder diagnosis given to someone who really just gets anxious about a lot of things. So a lot of different things that make them anxious, or they just experience anxiety, all of the time. Maybe sometimes not even really connected to anything immediate to them, or maybe even anything that they are aware of. They just feel anxious. Now, I talk about this disorder, but it actually tends to be the disorder that we want to diagnose last when we're looking for anxiety, because it's the least descriptive. It just says this person's anxious. And like I said, we've got so many anxiety disorders now that there really are a lot of them that we could choose that would be more descriptive and probably more helpful in their treatment if we can really nail down what it is they're anxious about. So just a couple of them include things like what we call specific phobias, and these are things that you've heard: arachnophobia, claustrophobia, these type of things, whatever the clownophobia is that everybody seems to have these days. But the specific phobia is just a way of broadly naming any type of phobia that a person might have. So there's one. We've also got agoraphobia, which is a strange name because it actually isn't. But it isn't a specific phobia. Really, what agoraphobia refers to is a fear of open spaces. That is to say, these folks usually are guarded in the sense of always wanting to look over their shoulder and make sure that nobody's going to hurt them. A subtle agoraphobia symptom that I've seen a lot of folks, and this doesn't mean you have agoraphobia, this is just something that people do that an agoraphobic would certainly do, is go into a restaurant or into some building, and when they're seated, they have to be facing the door, or they have to be facing everybody else, or have their back to a wall such that they can see everyone. I know a lot of people who do this, but that's kind of the sense of what agoraphobia is, right? But they feel this way about everything. So if they're walking through a supermarket, if they're walking through a park, if they're walking anywhere where they're going to have a hard time seeing everything that's going on around them, that's going to cause them a lot of anxiety. One thing that's interesting about agoraphobia is that it is its own diagnosis, but it is also a symptom. It tends to be, for instance, a symptom of PTSD, which is another type of anxiety disorder. And folks with PTSD, of course, this is one of those disorders that they actually took out of anxiety disorders and gave it its own category called traumatic disorders. But PTSD, post-traumatic stress disorder, comes from a person who's had a really traumatic experience. And one thing I like to kind of rant about is the fact that people like to use this word trauma too loosely. When we talk about trauma in my abnormal psychology class, there is a specific definition and actually a list of things that are classified as trauma, and they basically include near-death experiences, sexual violence, and witnessing near-death experiences. That's kind of it. And so a lot of people, and sometimes they're just joking, oh, that test traumatized me, or, that argument traumatized me, this type of thing. But other times, folks really think this is what trauma is. And I just think we have to be careful about that, right? Stress is not trauma. Trauma is trauma. So but what happens with somebody who's got PTSD is they experience that type of near-death experience, or some type of, usually some type of brutal sexual violence. And what happens to them is that they gain this really intense fear around a lot of things that have to do with that incident. So that might look like they don't want to go near the thing, or things that remind them of that incident. They have a lot of anxiety around, or it scares them into a panic attack. They may have nightmares about the thing. They may have, flashbacks about the thing, right? That kind of typical, almost tropey, the veteran with PTSD at the fireworks show type of thing. But all of these things, right, are just a way to avoid that trauma again, or just ways to say, hey, I don't want to get near that thing again. So anything like that, I'm going to be, and we use this word, hyper vigilant. I'm going to be hyper vigilant about things that might bring me in contact with that trauma again. So things that sound like a gunfight, some women who have been sexually assaulted, right, don't want to be near men for a while, if ever. These type of things, right? So you really see these type of guarding behaviors that occur when somebody has trauma, and that's what we call the PTSD, is these flashbacks and these nightmares and these worrying, and often drinking or some type of substance abuse to kind of dull the behavior, or keeping yourself inside because you're afraid of the agoraphobia. All of these different things, combined with, of course, the anxiety that person is experiencing, are the result of that first trauma, or sometimes that repeated, or in the worst cases, ongoing trauma. So those are probably two of the biggest. I think I hit three of the biggest anxiety disorders, but one more that often comes up, and this is one that I saw a lot of when I was working at college counseling centers, is social anxiety. It used to be called social phobia, but that was another one of those things that is kind of not the best name for it. So social anxiety is a better name. So social anxiety disorder, these are going to be folks who have a hard time being seen in public. Sometimes what's interesting is this particular disorder can look a lot like agoraphobia on the surface. I don't want to go out to places. But with a social anxiety disorder, the fear isn't that, somebody's going to come up behind you and hurt you, or that, something's going to jump out of the bushes from over there. The fear with social anxiety is that people are going to judge and ridicule you, either out loud or just in their head. That if I have to get up in front of class and give this speech, everybody's going to think I'm an idiot. They're going to be laughing at me. I just can't face that embarrassment. Or if I have to go to this party and I don't know anybody, everybody's going to think I'm stupid. I don't know what kind of shoes to wear. I don't know. But they're going to worry about these type of things that people may be thinking about them, what people may be judging them about. That's really the social anxiety. And again, I saw a lot of this when I was working on college campuses, where folks were often just coming to college, just coming out of the experience of high school sometimes, or sometimes they'd been there a while and hadn't made a lot of friends, and maybe college was about to end and they were trying to figure out how to get out of their shell before it's all over with. So all of these different ways that social anxiety could affect people's life. And again, it was pretty common that I would, see this in college students. Again, it's usually all in their head. It is something that the person is imagining other people are thinking about them. And so the clinical work, just to give you a piece of that, is often about trying to get that person to explore those thoughts. Well, how do you know they're going to think your shoes are stupid? Has anybody ever said anything? Okay, well, do you think your shoes are stupid? Why are you wearing stupid shoes, right? So you're gonna just explore that process with them, and usually try to get them to break open the fact that really they're the one responsible for that judgment. They're the one that's thinking people are going to ridicule them, and they can let go of that, or maybe people are ridiculing them, and so we got to move past it. So what? So again, those are a good number of the anxiety disorders. There's many, many more. If you're interested, take my abnormal psych class. We'll talk about it. The next two I want to talk about are depressive disorders, and then we'll talk a bit about schizophrenic or psychosis or psychotic disorders. Depressive disorders, there aren't as many. Mainly when we're talking about a depressive disorder, we're talking about major depressive disorder, which is just depression. And so this is something you've probably all heard a lot about. The one thing that I would note about depression is that it can look a lot of different ways in a lot of different in different people. So the typical way that we think of depression is the person is sad, and maybe they're mopey and they don't want to go out, and they've kind of stopped eating, or they're sleeping too much, or maybe they're overeating and sleeping too little, right? But some kind of low, comforting themselves place where they don't want to deal with much, and they're sad all the time. And that's certainly a way that depression can look. But other folks maybe do things like they're not quite sad, but maybe they're just numb. And so they don't want to do the things that they used to do. They just don't want to hang out anymore. They still go to work and they still go to class, but they could really not be bothered with hanging out with their friends or doing any activities that they used to find enjoyable. And in particular, this can be the case with men who sometimes experience a form of depression that was almost put in the DSM called male depression or masculine depression. And women can experience this version of depression too, just as men can experience a typical version of depression. But this version of depression is met with anger. It's instead of that sadness, you're typically going to see more anger. You're not going to see as much drawing away from everything. In fact, you may see drawing away from some things, but maybe throwing themselves into something else. So sometimes what you'll see with guys who are depressed is they start going to work more. They're going to work earlier, they're staying later, they're just doing more work, or they're doing more class work, or they can also just be trying to distract themselves. So maybe it's not as productive as work is. So maybe they're throwing themselves into video games or something like that as well. But basically they're just trying to distract themselves from their feelings. So rather than feeling that sadness, right? Guys are taught, don't be sad. So rather than experiencing that sadness, often what they'll do is try to distract themselves with something else. And so what you get is a type of depression that doesn't look sad and mopey, but it looks angry and leave me alone, I'm going to work, leave me alone, let me handle it, stop, why are you bothering me so much, right? It's this type of tone. Which before we really knew that depression could show up this way, sometimes this would get misdiagnosed. These folks would just get sent to anger management, or they'd get sent to some type of substance abuse program, because that's another behavior that guys often engage in when they're feeling depressed. And again, rather than experience those feelings, let me drown them or smoke them away, or whatever it may be. And so oftentimes they get sent to these things, and some of those things are helpful, but really, if we know it's depression, well, now we're looking for what that loss is. Depression, in 100% of the cases that I can think of that I've seen, and I would bet money on 99% of the cases, have to do with some sort of loss. Again, it could be a death, and sometimes, again, a death of a loved one doesn't normally cause depression, but it can, again, if that distress is really out of the ordinary. Again, you never can go to work again, you never can leave the house again, right? That would be some type of grief that we would say this is starting to look a little more like depression. So loss of a loved one, loss of a job, loss of respect, loss of a career, loss of your sense of pride, or whatever it is, loss of your ego. All of these things are the things that we tend to see leading to depression. And again, if you've got this version of the depression that's hard to recognize, if you don't know to go in and sort of talk about that loss, you had this really successful job and now you've lost it, and I see you're working really hard to get another one, and you're yelling at your family and you never come home at night and this type of thing, right? If we can deal with that loss rather than just saying, hey, you need to go to anger management and stop being so angry, well, that's not going to get to the root of the problem, which is how you really begin to heal someone. Okay, so last thing we'll talk about is schizophrenia. And schizophrenia is a type of disorder that we call a psychosis. And a psychosis basically means, in sort of an old psychological language, today it basically means schizophrenia, but what it used to mean really was that somebody's disorder was so severe that they themselves didn't even notice anything was wrong, that they were caught up in the disorder so much that they didn't know that something was wrong, or the nature of the disorder was such that it takes you over such that you don't know anything's happening, or you believe the things that's happening, right? So again, of course, I'm talking about things like schizophrenia, where you're hearing voices and you don't know that you're hearing voices. And this is one of the things that's often misunderstood about schizophrenia is usually, unless somebody's had some treatment, unless maybe they've had schizophrenia for a long time and they've done some work to recognize what's going on in their mind, usually if somebody's hearing voices or seeing things or smelling things or any of these type of hallucinations, usually they are going to believe that that's happening. And the voices won't be seeming to come from their head, their voices will be seeming to come from, what's that over there? I think I hear something, right? Oh, yeah. No, I can't do that, right? That's what schizophrenia is more like. It's not like you're just in your head hearing things. It's you actually think something's talking to you, or you actually think that you see. Does everybody see this? You actually think that you see this thing. And so one of the main features of schizophrenia, or one of the main things that we use to diagnose it, are going to be things like hallucinations. Auditory hallucinations are most common, or something that we call delusions. And you've heard of delusions, but a definition or a description of that is that delusions are things that you believe to be true that aren't true. So in a hallucination, you're having a sensory experience. I think something's not there. I think I hear somebody talking to me, this type of thing. In a delusion, you never really see anything, but it's just a belief. I think the aliens come and get me every night and take me to their spaceship and do some weird probes, and that's why I'm gaining weight. So the delusion piece is the belief, right? It's that belief that something is happening. Somebody's after you, right? A paranoid delusion. The government is tapping on my phones and they're going to come and get me as soon as I say the words red on the phone or something. This type of thing. So either the hallucinations, the seeing of things, or the delusions, the believing of things, are the main two features that we're going to look for when we're talking about schizophrenia. There are a couple other things that might be symptomatic. So there's stuff that's called disorganized speech and disorganized thinking. Disorganized thinking is when you can tell that the person is speaking fluently. That is to say, they're saying words, they're saying sentences that should add up to things, but when you put it together, that doesn't make any sense to you. So yesterday I saw this bird on the top of my roof and it was blue, and I just knew it was going to rain because blue birds definitely mean rain. And so I had to get inside and make sure that I took all the grass inside too, because you don't want your grass to get wet. That ruins it, right? All right, back to the real person. So that type of thing would be a type of disorganized thinking. They're speaking clearly, they're saying sentences again that make sense, but they don't make sense. The logic of what they're talking about doesn't make sense. So disorganized thinking. Disorganized speech is where blue, purple, red, and green fart and then flew up to the sky red now. is disorganized speech. That is to say, people just start saying nonsense words, right? Now the words don't even make a sentence, or the sentence doesn't make any sense at all, this type of thing. So you can have this type of disorganized speech, you can have this type of disorganized thinking. Again, they are gonna typically, for a true schizophrenia diagnosis, be paired with either that hallucination or delusion. There's also a few behavioral abnormalities that we can see sometimes. So sometimes it's called disorganized movement to go along with the other ones. But usually that disorganized movement, it might be like some type of twitch, though often the twitches that you see with somebody who's got some type of psychosis are the medication. The medication causes those kind of neurological twitches, but you might see them just like, doing something weird with, with their hair. I don't have any, but doing something weird with their hair, or sometimes something we call catatonia, where they'll just freeze, or part of them will, I can't move my arm, it won't move, and then you go over and you move it and it moves, right? It's kind of like Gumby, and maybe it floats back to where it was. That's what we call catatonia, and sometimes you'll see folks also have these type of behaviors. So that's schizophrenia, in terms of its symptoms. One of the things about schizophrenia that a lot of people also don't know is that it tends to show up pretty late. This is, again, why I said schizophrenia is kind of a developmental disorder. People get diagnosed with schizophrenia differently depending on if you're a man or a woman. On average, men get diagnosed with schizophrenia around the age of 25, and women get diagnosed with schizophrenia around the age of 40. And so, first of all, there's this really, wide gap between those two ages. And then we have to also ask ourselves, why is it waiting until adulthood anyway? It turns out, and this is fascinating, that estrogen is actually a protectant against schizophrenia. So the reason guys tend to get diagnosed in their 20s is because that's when they're sort of at their max power, the prime of your life. That basically means you've got a lot of testosterone flowing in your 20s, and because of that, the ratio of estrogen in your body is a lot lower, and so you don't have as much protectance against this psychosis coming on. Whereas for women, their estrogen is going to be lowest around the time of menopause. And so as they get closer to older age and get closer to menopause, their estrogen is going to drop off, and again, that is going to lower their protection to psychosis, and so they may develop schizophrenia at that age. Now, schizophrenia tends to run in families, so I hope I'm not freaking you out, because I know what it was like for me when I was, in my early 20s, to hear that, I still wasn't over the hump yet. And I can't imagine what it's like for women. You got a while to wait. But generally what you find is that schizophrenia runs in families. It's genetic. And so this is something that you don't need to worry very much about at all. It's pretty rare in general, but certainly don't need to worry about it too much if it's not in your family at all. So this tends to be something that's genetic. You can kind of get a short-term schizophrenia psychosis. We call that brief psychotic disorder. That tends to arise almost like a PTSD. Some type of trauma happens to you, and then you just detach from reality. You start hearing voices, or you start having disorganized thinking or something. But usually in that brief psychosis, you get over it. A true schizophrenia that's going to be with a person for the rest of their life is just a developmental thing. And again, it tends to run in families. One question I tend to get about schizophrenia is, can drugs cause someone to develop schizophrenia? The short answer to that is no. What we do know is that if a person is probably gonna get schizophrenia anyway, that is to say, it runs in their family, they are about at the age, they're getting close to that psychotic break, right? You start to see people might start to do small, strange little behaviors. You'll see little delusions happen, right? That bird is trying to tell me something, right? They don't go on about the sky and the rain and all of this stuff, but they might just say, hey, is that bird talking to you? No, that's weird. Birds can't talk, right? And so you might see them kind of having these little bitty breaks, and then that'll build up, and it progresses over time. So sometimes if folks are, right on that verge anyway, and they do some type of psychotropic substance, some type of, mind-altering drug, that can be the little push that nudges them over the edge. But you should understand, right, that these things aren't just causing them in and of themselves. There used to be some literature that thought that, but what was happening again were the people that were reporting that were just right on that verge anyway. Okay, so that's all I have to say about schizophrenia. There's a lot more. Again, if you're interested in this type of stuff, I do teach a class, and usually both spring and fall semesters, abnormal psychology. Love to see you there. Hopefully not like this, but might be. And then lastly, I just wanted to tell you a bit about the exam. I'm not going to tell you much, and that is by design. So this will be an open book, exam, as things, have to be these days. It will also be an essay exam, and in some ways it'll be very similar to the first exam you took from me right before spring break. And it will be a cumulative exam in the sense that I want you to know something. I want you to know a lot about some things. You don't have to know everything, but the way that you should study for this final is to go learn 2, 3, 4 things pretty dang well, and then when you show up for the final, you should be prepared. Again, you're going to have to write about some of these things. You're going to have to kind of be verbose, that is to say, I'm going to want to see you talk a bit about them. So you did pretty good jobs on the first exam, so I think you'll be okay with this one. Expect that to be posted most likely next week sometime, and then you'll have till the end of finals week to get it back to me, and I'll put a place on Blackboard, I think, for you to deposit it there, so you're not blowing my email up with the finals instead of questions if you have them. Okay, it's been awesome, guys. This has been, again, a really weird way to have class, and hopefully in the fall it won't be this way. It might be, unfortunately, but hopefully it won't be. And if you see me in the hall, say hello. I might not recognize your face. I apologize. It's been a long time, but hopefully this helps you know what I look like. So I'd appreciate it if you said hello when you see me. All right, take care, and have a good summer.